Hi everyone. My patient was an 81-year-old Caucasian male with a past medical history of coronary artery disease, status post stents, who presents today with a complaint of syncope with dizziness and chest pain and shortness of breath. The onset was 7 p.m. last night. The patient states the pain is in the middle of his chest. It comes and goes. It is worse with exercise. The patient rates his pain a 5 out of 10, and the patient states he did not take anything for the pain at home, but was given aspirin and nitro upon arrival to the emergency department with no relief. The patient states that he was at the gym, and this episode happened after he returned back home. The patient states he works out regularly and has not been ill prior to this episode. The patient denies a cough. He also denies nausea, vomiting, or diaphoresis that accompanies his symptoms. The patient was admitted to the intensivist service for further management in the cardiac ICU. The patient has no known medication, food, or environmental allergies. His home medications include Synthroid 137 micrograms once a day in the morning, Ativan 0.5 milligrams 3 times a day as needed, and aspirin 81 milligrams once a day in the morning. His past medical history includes coronary artery disease, status post stent placement 7 years ago, osteoarthritis, melanoma, and hypothyroidism. His surgical history includes a heart cath with stent placement, bilateral knee arthroplasty, and bilateral hip arthroplasty. The patient's family history includes coronary artery disease and hypertension from his mother, hypertension from his father, and coronary artery disease from his brother. For his social history, he currently lives at home with his wife. The patient is retired. His highest level of education is high school. The patient states he is active and exercises at least 3 times a week on an elliptical. He denies tobacco or illicit drug use, but the patient reports drinking 1 glass of red wine every night. The patient was not in the military and has not recently traveled outside of the United States. He requires no home aids, and he ambulates independently and performs ADLs independently at home. His review of systems was negative other than what was mentioned in the HPI. For his physical exam, the only abnormals were an irregular heart rate. There were no murmurs, no adventitious heart sounds. His lung sounds were clear to auscultation bilaterally. There was no respiratory distress. The rest of the systems were normal. For his vital signs, his blood pressure was 99/81, SAT of 95, heart rate of 102, respirations 18, and a temp of 97.5. For his diagnostics, his EKG showed AFib. His initial EKG in the emergency department showed AFib with RVR. We got a CT angiogram of his chest and abdomen, which showed cholelithiasis, a small pulmonary embolism in the right lung, and a prominent thrombus in the left atrial appendage. We also obtained an echo, which showed also the thrombus in his left atrial appendage and an estimated left ventricular ejection fraction of 20 to 30%. His chest x-ray was normal, his lungs were clear bilaterally, and there was no evidence of an acute cardiopulmonary abnormality. His CBC was within normal limits. His electrolytes and all of the elements of his CMP were also within normal limits. His pro-BNP was 3,212. His troponin peaked at 0.06. His D-dimer was 11.5, which is what prompted to get the CTA. And his INR was 1.1. So his diagnoses included a thrombus in his left atrial appendage, pulmonary emboli, new onset AFib, congestive heart failure, and coronary artery disease. His chronic diagnoses include his hypothyroidism. So for his acute atrial thrombus in his pulmonary emboli, we treated it with a therapeutic dose of Lovenox, as well as warfarin. So the therapeutic dose of Lovenox is 1 milligram per kilogram sub-Q every 12 hours. The patient weighed 86.1 kilograms. So we rounded the dose up to 90 milligrams sub-Q every 12 hours. The patient's initial INR was less than 1.5, therefore the patient was started on 5 milligrams of warfarin once a day with a goal INR of 2 to 3. We did determine that if the patient, once the patient's INR became greater than 1.5, he would be able to discharge because we would then know that it was trending upward appropriately. We also ordered a TEE. The results were pending, and that was because a transesophageal echo is the gold standard for diagnosing a left atrial appendage thrombus. The patient's slightly elevated troponin and pro-BNP was most likely related to demand ischemia instead of congestive heart failure. Cardiology was consulted. So for his left ventricular ejection fraction of 20 to 30% on his echo, the patient does not appear fluid overloaded on exam at all, and his chest x-ray also did not appear that he had fluid in his lungs. His new onset AFib, he stated that he had never been diagnosed with AFib before by his cardiologist. So for this, he was on a telemonitor all the time. He's already anticoagulated on therapeutic Lovenox and also warfarin for his clots. And then we also added a beta blocker for rate control. A TSH and a free T4 was pending. We ordered these because hypothyroidism can increase the risk of AFib. So if he was already on Synthroid at home, but if it was not the correct dose, and he was still having symptoms of his hypothyroidism, then that could be what caused his atrial fibrillation. So in that case, if his TSH was still high and his free T4 was still low, we could adjust his dose of Synthroid appropriately to hopefully prevent further episodes of AFib. For his cholelithiasis on his CTA, he didn't have any symptoms of cholecystitis at this time, so no surgical intervention or antibiotic therapy would have been appropriate because he was asymptomatic. For his chronic coronary artery disease, he already has a cardiologist. We did suggest that he see his cardiologist 1 week post-discharge, that he continue his aspirin once daily as well as his warfarin. For his hypothyroidism, like I mentioned earlier, we did order a TSH and a free T4, but at this time, while those labs are pending, we will continue his home meds. The patient is already covered for DVT prophylaxis with his therapeutic dose of Lovenox. So the medications that he was given during this hospital stay were Coumadin 5 milligrams once a day, Lovenox 90 milligrams sub-Q BID, and metoprolol 25 milligrams PO BID. We continued his home Ativan and his home Synthroid, and we did suggest that the patient follow up with his primary care provider as well 1 week post-discharge.